Hello and welcome to Open Line. I'm Starlene Stringer. Well, doctors, patients, and staff are settling into an all-new and super huge Parkland Hospital in Dallas. Irving voters were among those who approved funding for the more than billion-dollar building. Today, we are going to learn all about the hospital as well as some of Parkland's initiatives. Our guests are Chris Gaw, Executive Vice President and Chief Administrative Officer of Hospital Operations. Dr. Luigi Meneghini is Executive Director of the Global Diabetes Program, as well as a professor. And Sharon Phillips is Executive Vice President and Chief Administrative Officer for Population Health, and she knows all about Parkland's clinic in Irving. I want to thank you all so much for being here.
Thank you, Charlene.
Well, I said that Parkland's new hospital is huge. It's big. Exactly how big is it?
It's 2.1 million square feet.
Wow, that is big. That's super, super big. Why did Dallas County even need a new hospital?
Well, the hospital across Harry Hines that we previously were in is from the 1950s. And so it was an aged facility. And the citizens voted at 82%, stating that the community needed another facility. So both the aging of the facility as well as advancement in technology and medical equipment.
I see. And Dr. Meneghini, I know that there are a lot of initiatives for Parkland right now, especially the new Parkland, but one thing that you're really focused on is diabetes. Why is that?
Well, because diabetes has been recognized as a huge problem, not only nationwide or in Texas, but also within Dallas County. And I think that Parkland has realized that and focused a lot of resources, effort, staff, monies towards trying to address the huge diabetes issue in our county, which I think is tremendous because it is unique in the United States for a safety hospital to put this much effort into addressing an issue which is in many cases thought as a loss of money. For example, there are hospitals that are closing their diabetes program because it costs them money. Parkland is turning that around. It's looking at improving diabetes care because it knows that down the line it will pay dividends.
I see, and I understand that you're actually part of a global diabetes program. What exactly does that involve?
Well, Global Diabetes Program sounds like a good name, doesn't it?
Yeah, it does.
Yes, global. And actually I'm asked, well, where in the world do I travel? But right now we're focusing on building the infrastructure within the Parkland Health System.
Okay.
And as you heard, there's a beautiful new hospital that has opened. It is just, it gives me goosebumps when I go in and work in there, just in terms of the quality, the efficiency, the beauty for the residents of Dallas County that go there and for those of us that work in there. In the hospital setting, there's a lot of diabetes that needs to be taken care of. That's a critical factor. We have specialty clinics which we have expanded to take care of the more complicated issues with regards to diabetes. And we work very closely with the primary care network in the Parkland Health System. So the COPCs, and Irving has a COPC that have diabetes activities. They have American Diabetes Association education sites. They have primary care physicians that take care of a lot of diabetes. And we're trying to bring together an infrastructure that supports them, that brings specialty care to the community, as opposed to having patients having to come in and get that specialty care, and trying to standardize some of our approaches to providing quality diabetes care.
I see, I understand. And I'm glad you mentioned the clinic in Irving because, Sharon, there are people who until today had no idea there was a clinic here in Irving from Parkland. So can you tell us exactly where it is and what it's called?
Sure. It's called the Irving Health Center, and it's at 1800 North Britton Road, right below 183. It's been there since 2007. And it was Parkland's first adventure into partnering with cities to place services in their communities. So I worked very closely with the City Council and with the City of Irving to put together a business deal that allowed us to build that site where it is now.
Okay, and are there any other partners involved or mainly just those two?
Baylor Irving participated as well, and we work closely with Baylor Irving. Sometimes patients that we could be seeing in our clinics come to the emergency department there, so they'll do their assessment there and then they will refer to our Irving clinic.
I see. Now back to you, Chris. What type of patients do you serve at Parkland?
We serve basically any patient that walks in. So anything from, the neonates in our neonatal intensive care unit to trauma patients, whether that's a motor vehicle accident, a burn patient.
Helicopter crash, I was brought there.
Helicopter.
Could be any of that.
Helicopter crash,
Yes.
so trauma patients, psychiatric patients. So really any discipline.
Okay, and I've heard the term safety net hospital. What exactly is that?
So that is really, Parkland being a safety net hospital means that we serve whoever comes to our door.
Okay.
So really regardless of their ability to pay, if they're a Dallas County citizen or they present with that trauma, we're gonna help them.
Wonderful. Dr. Menegini, I want to go back and talk about diabetes for a minute. Why is it so important to actually be diagnosed quickly?
That's a great question because diabetes, for the most part, is a silent disease. You have high blood sugars, you may have diabetes and not know it, and that's a good portion of the people that are out there because it doesn't give you symptoms that you recognize. And by the time that it does give you symptoms, you start losing your eyesight, you start having kidney problems, you start losing sensation in your feet, which leads to the risk of amputation, it's already late. Diabetes is one of the leading causes of cardiovascular disease. It is the #1 cause of non-traumatic amputations, #1 cause of blindness in adults. All of it entirely preventable if we are to recognize it early and treat it appropriately.
I see, and a lot of that comes to just talking about this with your family members too, I understand, because sometimes when you go to the doctors, they always ask you have a history of this in your family, and a lot of families these days don't talk and communicate and share that information, so it is important to know if your parents or grandparents had diabetes. Isn't that correct?
Absolutely. You make an excellent point because when you look at the risk factors for having, for example, type 2 diabetes, family history is probably one of the biggest drivers. You inherit the risk of type 2 diabetes. And your environment also drives that. So as you get older, as you get heavier, as you get more sedentary, your risk of developing diabetes increases. There are the risk factors that we consider, and we can use that to kind of screen individuals for having diabetes or prediabetes. And that's very useful because not being a disease with symptoms for the most part, we can identify high-risk people and do the right test to diagnose either diabetes, prediabetes, or tell them that they're doing okay.
Wonderful. And Sharon, I understand there's progress being made on special programs for diabetics at the Irving Clinic. Can you tell me about that?
Yes. Quite a number of years ago, we became certified by the American Association for Diabetes, and then since Dr. Menegini has joined our organization, he's working with our medical directors and our nurses to advance the diabetic care that we provide in the community here and across all of the COPC locations across Dallas County. And COPC stands for Community-Oriented Primary Care. So we want to be out in the neighborhoods where people live, where we can serve them easier. It's more convenient for them to come to our locations.
Well, what are some of the other services provided at the Irving Clinic?
Well, we have a whole array of services for adults and with pretty much any kind of chronic disease condition we take care of there. We also see patients for acute conditions such as sore throats and ear infections. We serve adults, pediatrics, and geriatric patients with our geriatricians at some of the sites. We also have radiology services. We have a mammogram van that comes around to the site, so we offer mammography at the locations. We have lab services on site. We also have women's services on site, GYN services, as well as OB pregnancy services for families and for women.
Interesting. Thank you for letting us know about that.
You're welcome.
And Chris, I want to come back to you now and talk about the main campus of Parkland and some of the departments there, starting with the trauma department. Who is served there and what are the improvements?
So the trauma department is, as we talked about, it could be the helicopter
Yes.
ride that gets you there. It could be the motor vehicle accident. So there, any form of trauma,
Okay.
penetration. There's a variety of different criterion that qualifies for being a trauma patient.
I see.
And so the Reese Jones Trauma Center at Parkland is capable of 10 trauma bays. They are basically double in size of what they used to be.
Wow.
They have, you will hear it said that it's a digital hospital. And when we talk about that, one of those enhancements is the trauma center. That is in room and in bed, if you will, digital imaging. So when the patient is x-rayed, the imaging comes up on a screen while in the trauma room. So you can imagine when you have broken bones and severe injuries, being transferred and moved around is risky.
Exactly.
And so that is an advancement in trauma care specifically.
Good advancements. Also changed is the emergency department. What's new there?
The size of the emergency department.
Huge, huh?
Would be,
They all say with a smile, they're like, it's huge.
as Dr. Meneghini says. So the size, 154 treatment areas in the emergency room.
Wow.
So that alone, the private room, if you were in the previous location, it was chairs. So privacy was a challenge. And so with the privacy of the rooms, that is certainly a much more cohesive environment, both for the treatment of the patient, the privacy of the patient, the infection control of the patient. So it really touches all aspects.
I see. And are you seeing a change in wait times at all?
You know, as we grow, you know, when you move into a new home, you know you're unpacking boxes and you're moving in, so maybe you have certain challenges with that. We've also seen our volumes really increase. I think people have they know we're there, and so it's with the things not necessarily staying the same, with the baseline not staying the same, it's hard to say exactly. So
that's understandable. Yes. And Dr. Meneghini, I want to come back to you now and ask, what exactly are some of your goals for the diabetes program?
Well, there's a number of goals. The diabetes program was started based on 1115 waivers that had very specific goals. And they were, for example, trying to identify individuals who had very poor diabetes control and trying to get a percentage of them under better control.
I see.
Making sure that individuals with diabetes get the required screening tests. So, for example, a yearly eye exam or a foot exam, or the right labs to detect whether they have any kidney disease or not. And so those are very specific goals. One other goal that was very important was that we wanted to be able to expand our volume capacity, meaning be able to see more patients with diabetes and meet the demand. You can well imagine 30% of the patient population that comes through has diabetes. Now, not all of it uncontrolled, thank goodness, but a lot of them with a lot of serious complex issues to deal with, which diabetes makes even worse. And so that part has been very important. We've been putting together the infrastructure for the past year and a half, and now we're starting to look at ways that we can capitalize on that infrastructure through IT technologies to identify our highest risk patients, to try and direct resources, because we are, after all, still resource limited, but direct resources at the right patients and maximize our ability to improve care for those that need it most.
I see. And Sharon, I want to come back and talk to you about two particular services offered at the Irving Clinic. One would be the social work service department, and then the other is psychiatric. Can you tell us a bit more about those?
Sure. With our patient population, frequently it's very, very important to have a social worker available, and we typically have a social worker for our adult patients as well as one for our pediatric patients. Because what we find is, in approaching the care of someone, you really have to put it into the context of their life. And social workers help us have conversations with the families and with the patients to ensure that whatever medical treatment plan that we work out with the family and with the patient fits within their life. And the social worker can make referrals if they need food services or job possibilities or things like that. Our social worker can really help them link into the community to help stabilize their lives a little bit better so that any medical treatment is more likely to work. And then at the same time, our social worker staff works in kind with our psychiatric and psychology group to make sure that, particularly with diabetes conditions, a very common factor in diabetes is also depression. So we're really trying to focus on depression, focus on good screening as patients come into the health centers or really across the entire system to make sure that we understand how that person's doing from a psychological point of view, and are they depressed, are they really anxious about things, and both psychiatric services as well as social work services help support and provide better infrastructure, if you will, for the family and help them link up, as I said, with different resources in the community as necessary.
Nice. And I want to ask you another question too. Do patients at the Irving Clinic need insurance?
About 42% of the individuals that we see there are uninsured, and Parkland has a patient financial assistance program that we use for those individuals, as well as with each new person, and then periodically thereafter they will have a financial classification process done with them. And we have tools in place that search against, I think, about 128 or so different programs that families or patients might be eligible for.
Okay.
We're also capable of helping patients get on Medicare and Medicaid, or the CHIP program, or another one's called Perinate for women. So we have resources at all of the locations to help us put patients into programs that will allow them to feel more comfortable in accessing services.
Okay, thank you.
You're welcome.
And Chris, while we're talking money, a lot of people are curious to know how the construction for the big new hospital in Dallas was paid for. How was it funded?
So as we talked about earlier, 82% of the voters passed the bond.
Right.
That funded the majority of that. And then Dallas, being a very philanthropic community, raised $150 million towards the campaign as well. So, and then the remaining came out of operations. So about, when you do that math of the 1.3 billion, about 800 million of that was the bond, 150 of it was the philanthropic, and then the rest came out of operations.
So who's counting, right?
Right, you know.
But some
roughly.
Of the, yeah, roughly. But some of those donors, they also have recognition, I understand, in the hospital, isn't that right?
They do.
It's a donor wall?
There's a donor wall, so there's everything from the big donors who have their name on the outside of the hospital, and then there are everything down to, you know, $10 donations that have their name in the tree etching of the glass that
All
you
of it
see
adds
as
up.
you drive down Harry Hines.
Beautiful. We were looking at some of the video of that while you were talking, and it's really gorgeous. Came out very nice. I know Parkland is also known for the number of babies born there. So tell me about the facilities now for expecting moms. So
there are 96 neonatal intensive care private rooms. So that is a different model. So in the event of a high-risk birth, there are those, and then the 44 what are called LDRs, so the labor, delivery, and recovery rooms. And then the concept of the postpartum units are in room with the infant, but we also have newborn nurseries as well. So it's really, the intent is for the mother and the baby to be together through that whole stay in a private setting, which is something new that is in new Parkland that was not in the previous Parkland.
Well, I had my first and only baby 2 years ago, and I can tell you it feels good to know the baby's right there, so I'm sure the new moms love having that, so great for there. Another thing that I know a lot of people talk about and what Parkland's known for is the burn unit. Can you tell us about that too?
Yes, so the burn unit, second largest in the United States, is, Parkland is actually known for having the textbook is taught much of what UT Southwestern, so again, to emphasize the partnership between Parkland and UT Southwestern. So the burn unit has expanded, and so we have the burn intensive care unit, the burn unit itself, and then we have an outpatient burn clinic within that space.
Okay, thank you. And I want to come back to you now, Dr. Meneghini, and I know there are a lot of myths when it comes to diabetes. What are some of the myths that you'd like to clear up about it?
That's a great question, and it's wonderful that you actually asked, because we struggle often to get the right treatment in the right patient. And it's not because we can't figure out what the prescription needs to be, but there's two things that need to happen. One, we need to have a a really engaging conversation with the patient, get on their same level, and get them to understand that what we're trying to do is care for them and provide them the best options. A lot of times, if you've had diabetes long enough, type 2 diabetes, which is the most common one, you're going to run out of insulin, and you're going to need to replace that insulin if you want to control your blood sugars and avoid complications of the disease. And that conversation is a difficult one because there are a lot of myths surrounding insulin, and it depends on the type of community. But for example, in the Hispanic community, they associate insulin use with complications of diabetes because they know somebody that started insulin therapy and within a few months or a few years was on dialysis or had their limbs cut off. And they don't realize that the reason that happened is that they did not start the insulin early enough to control the blood sugars and prevent the complications. But to get to that point and to get the message across in an effective way, I think what we need to do is a better job of engaging patients. But that's just one of those myths. The other one is, well, if I have diabetes, my life is over. Your life is not over. I have a sister who has had type 1 diabetes for 35 years, completely healthy children, no complications of the disease, has been on insulin for all that time. So there are examples out there of people that have been able to manage the disease and do it so that it does not interfere with their quality of life, their longevity, and just their overall joy of life.
Good. I'm glad you told us that story about your sister. It definitely gives hope to some people out there who may have felt, diabetes, like you said, was
Absolutely.
meaning life was over, and it could just be beginning. After getting diagnosed, they can live better.
It's a great point because for many people it is. They
Yeah.
change, they become more healthy, they start watching what they eat, lifestyle changes, and it actually does make them healthier.
Awesome. Sharon, I have a question for you. There are a lot of diverse populations here in the Irving community. So what happens if someone comes into the clinic in Irving and they can't speak English?
We have people on site that are bilingual, and many of our staff, about 60% of my staff, speak Spanish. And then we have translator phones, and we have individuals that do translation on site at all locations. We also are beginning to use what's called Alvin, where you can see the translator, but it's over a screen. We don't use that in all cases. We prefer either staff being bilingual or the translators, particularly when we're first trying to get to know a patient or a family, because it's a little bit more intimate. And we feel that we get a better clinical outcome and a better result with the family in terms of understanding. We understand what's going on with them, and they can participate with us better in their care.
Makes good sense.
Yeah.
Well, we're going to come back to you, Chris, because there's some things we want to understand about the new hospital, and I understand there's some really cool things that the hospital's been awarded for already, and that includes the environmental focus. Can you tell us about that?
So I assume you're referring to our LEED awards, the Gold Award, and that is about sustainability, so environmentally friendly, whether that is water savings that we're having, energy efficiency. It could be in the materials that we selected. It could be in the shrubbery. So, putting the park back in Parkland, for example, out front, having that be on a lower maintenance type of shrubbery that we're using. So all of those things go into play around that award.
Wow, you were taking a look at that. It's very beautiful too. And technology is at the forefront for sure.
Technology is.
How so?
So as we said earlier, as I said earlier on the digital hospital, so it's really geared around both a patient experience environment, but most importantly, patient safety. And so as Dr. Meneghini had talked about, even the providers' interaction. So for example, our beds, in many of those cases, they weigh the patient, and then they'll interface that information right into the medical record. And the headboard, if you will, and the footboard, if you're in the room, is digital, and that gives information through the pillow speaker. Will control it so that the patient then can interact with the TV, which is what's being referred to as the footboard, and they get information that way. We have what we call RFID, which is radio frequency identification. That is used for both security purposes, for infant security, but it's also used for tracking assets through the facility. So Not assets in the sense of the money component of an asset, but if you're looking for an IV pump and you need it urgently for a patient, you can go onto the system and see where it's located at. Where's the nearest one, so that you can access that piece of equipment more rapidly for the sake of patient care.
Very cool. And what about the interior design? Why were the colors and natural light so important?
Again, for that healing environment. So from a patient perspective, a patient experience, but not just necessarily the spa experience, if you will, but also from the healing perspective.
Very good. And Dr. Meneghini, before we end the show, I want to come back to you because I want to know what people can do to prevent diabetes.
Another great question. Type 1 diabetes, you can't really do much. But if we talk about type 2 diabetes that affects 90% of individuals with diabetes out there, there's a lot that you can do. Number one, be aware of what your risk factors are. There are risk factors that you can't modify. You can't really choose your parents, and so that genetic component.
A lot of people are like, man.
You know, choose your parents well. That's my first
right.
point of advice. Secondly, you can't change the age factor. I haven't found the fountain of youth, even though I stayed in Florida for a long time. But there are things that you can change. You can make sure that you don't become sedentary, that you increase your lifestyle. Diet, food intake is huge in terms of determining risk. Looking at ways of incorporating physical activity into your daily life. I personally don't have the time to exercise, even though I prescribe it all the time. But yet I can climb 2-3 flights of stairs. I can park my car, didn't park it too far today, but I was late. But park your car a block away from where you're going. Take every opportunity of incorporating some activity in your daily life. Get up from a chair every half hour, every hour. That's actually known to reduce your risk of cardiovascular disease. So there's a lot that can be done. I think main thing is to understand what your risk factors are and understand what you can do to mitigate those risk factors.
Perfect. And one more last question for you, Sharon, as well. Remind us again where the Irving campus is located, or where the Irving Clinic is, and also what people can expect when visiting.
Okay. Again, we're at 1800 North Britton Road, which is just south of 183, between Carl and O'Connor. And what people can expect is, again, back to what you were talking to Chris about just a minute ago, it's a very open center. It's very bright and lots of light. And so they'll have a good experience walking in. There's nice waiting areas. The time that it takes us usually to see a patient is about 60 minutes, sometimes up to 90 minutes. So their visit will not be prolonged and they won't have to wait for a long time. And then it's the way that we've set it up is kind of in an oval. So they will have, if they're an adult and they're going to go to what we call the adult module, they'll have their own waiting area and they'll wait there, and pediatrics their own, and then the women's clinic has their own, so that they're together with individuals that they share something with in case they know each other or want to have conversations with one another about what's happening with them. Awesome. Some of our patients come in, particularly our geriatrics patients come in, and that's a social event for them. So we've tried to make the environment really nice. We have doctors and nurses that will address them. Our clinical teams, our doctors and nurses work together as a team, and then they will pull in the psychologist or social worker or translator as necessary, depending on what the patient's needs are.
Wonderful. Speaking of working together, I want to thank you all for working together today to tell us about the new, big, huge Dallas Parkland location, the Irving location, and how we can hopefully prevent diabetes. Thank you so much for being here.
Thank you.
And thank you for watching. I'm Starlene Stringer. Please be sure to join us on Thursday, November 5th at 1:30 p.m. for our next edition of Open Line. Our guest will be updating the progress on the city's comprehensive plan. You can email questions to ICTN@cityofirving.org, and we'll get them answered on our next show. We'll see you then.